Alopecia areata, also known as spot baldness, is an autoimmune disease in which hair is lost from some or all areas of the body, usually from the scalp, due to the body's failure to recognize its own body cells and subsequent destruction of its own tissue. Often it results in bald spots on the scalp, especially in the first stages. In 1–2% of cases, the condition can spread to the entire scalp, alopecia totalis, or to the entire skin, alopecia universalis. There are two types: 1. Scarring alopecia, where there is fibrosis, inflammation, and loss of hair follicles, and 2. Non-scarring alopecia, where the hair shafts are gone but the hair follicles are preserved, making this type of alopecia reversible. Conditions resembling alopecia areata, and having a similar cause, occur also in other species. Typical first symptoms of alopecia areata are small bald patches. The underlying skin is unscarred and looks superficially normal. Although these patches can take many shapes, they are usually round or oval. Alopecia areata most often affects the scalp and beard, but may occur on any part of the body with hair. Different areas of the skin may exhibit hair loss and regrowth at the same time. The disease may also go into remission for a time, or may be permanent. It is common in children. The area of hair loss may tingle or be painful. The hair tends to fall out over a short period of time, with the loss commonly occurring more on one side of the scalp than the other. Exclamation point hairs, narrower along the length of the strand closer to the base, producing a characteristic exclamation point appearance, are often present. When healthy hair is pulled out, at most a few should come out, and ripped hair should not be distributed evenly across the tugged portion of the scalp. In cases of alopecia areata, hair will tend to pull out more easily along the edge of the patch where the follicles are already being attacked by the body's immune system than away from the patch where they are still healthy. Nails may have pitting or trichia. Alopecia areata is thought to be a systemic autoimmune disorder in which the body attacks its own antigen hair follicles and suppresses or stops hair growth. For example, T-cell lymphocytes cluster around affected follicles, causing inflammation and subsequent hair loss. A few cases of babies being born with congenital alopecia areata have been reported. Alopecia areata is not contagious. It occurs more frequently in people who have affected family members, suggesting heredity may be a factor. Strong evidence of genetic association with increased risk for alopecia areata was found by studying families with 2 or more affected members. This study identified at least 4 regions in the genome that are likely to contain these genes. In addition, alopecia areata shares genetic risk factors with other autoimmune diseases, including rheumatoid arthritis, type 1 diabetes, and celiac disease. It may be the only manifestation of celiac disease. Endogenous retinoids metabolic defect is a key part of the pathogenesis of the alopecia areata. In 2010, a genome-wide association study was completed that identified 129 single nucleotide polymorphisms that were associated with alopecia areata. The genes that were identified include those involved in controlling the activation and proliferation of regulatory T cells, cytotoxic T lymphocyte-associated antigen 4, interleukin-2, interleukin-2 receptor A, and EOS, also known as Ikaros family zinc finger 4, as well as the human leukocyte antigen. The study also identified 2 genes, PRDX5 and SDX17, that are expressed in the hair follicle. Alopecia areata is usually diagnosed based on clinical features. Trichoscopy may aid in establishing the diagnosis. In alopecia areata, trichoscopy shows regularly distributed yellow dots, hyperkeratotic plugs, small exclamation mark hairs, and black dots, destroyed hairs in the hair follicle opening. A biopsy is rarely needed to make the diagnosis or aid in the management of alopecia areata. Histologic findings include peribulbar lymphocytic infiltrate, swarm of bees. Occasionally, in inactive alopecia areata, no inflammatory infiltrates are found. Other helpful findings include pigment incontinence in the hair bulb and follicular style, and a shift in the anagen to telogen ratio towards telogen. The objective assessment of treatment efficacy is very difficult and spontaneous remission is unpredictable, but if the affected area is patched, the hair may regrowth spontaneously in many cases. None of the existing therapeutic options are curative or preventive. In cases of severe hair loss, limited success has been achieved by using the corticosteroids clobetasol or fluocinolone, corticosteroid injections, or cream. The cream is not as effective and it takes longer in order to see results. Steroid injections are commonly used in sites where the areas of hair loss on the head are small or especially where eyebrow hair has been lost. Whether they are effective is uncertain. Some other medications that have been used are minoxidil, Elocon, mometasone, ointment, steroid cream, irritants, anthraline or topical coal tar, and topical immunotherapy cyclosporin, sometimes in different combinations. Topical corticosteroids frequently fail to enter the skin deeply enough to affect the hair bulbs, which are the treatment target, and small lesions typically also regrow spontaneously. Oral corticosteroids decrease the hair loss, but only for the period during which they are taken, and these drugs can cause serious side effects. When alopecia areata is associated to celiac disease, the treatment with a gluten-free diet allows complete and permanent regrowth of scalp and other body hair in many people, but in others there are remissions and recurrences. This improvement is probably due to the normalization of the immune response as a result of gluten withdrawal from the diet,